periodontal disease most nearly fulfills Koch's postulates. Localized aggressive periodontitis. Question says, which periodontal disease almost fulfills Koch's postulates? Koch's postulates state that a pathogenic bacterium causes a disease. The disease is transmittable through the bacteria, and if you eliminate or control the bacteria, you eliminate the infection. This description is most descriptive of localized aggressive periodontitis. 2.
Fremitus.
Fremitus. Fremitus is a palpable pathologic occlusion bite, typically, typically found on one upper front tooth when a patient closes their teeth. This tooth vibration is considered an occlusal trauma. Signs and symptoms of a non-physiologic occlusion includes damaged teeth and restorations, abnormal mobility, fremitus, widened PDL, and possibly pain. Third, which teeth are most frequently involved in root amputation? This will be maxillary first and second molars. Root amputation and hemisection must be done in conjunction with endodontic therapy or of a particular tooth. Endodontic therapy is performed first, by followed by the periodontal therapy. Root amputations, the separation of an individual root from the crown. Most root amputations involve maxillary first and second molars, commonly involved periodontal sites. Burrs and diamond stones are used to severe to they're used to
Severe.
they're used to severe um, they're used to severe the crown and root before extracting by root tip forceps. Once the root amputation is complete, the remaining apical area of the crown and furcation region are recontoured similar to the shape of a pontic, so maximal access is provided for oral hygiene. Hemisection, the vertical sectioning of the tooth through both the crown and root. Usually a hemisection is used in the mandibular molar region, where the crown is divided through the bifurcation region. 50% of the tooth is extracted if one specific root has excessive loss in osseous support, and the remaining half of the molar tooth is now treated as a premolar. Question number 4. Which Miller defect responds best to mucogingival surgery? The answer is class 1 and 2. Which Miller defect responds best to mucogingival surgery? Class 1 and 2. Miller proposed a classification system for recession that has an influence on the success of surgical procedures. Class 1. In a Class 1, the recession is not extending to the mucogingival junction. No loss of interdental bone or soft tissue. In a Class 2, the recession extends to or beyond the mucogingival junction. No less of interdental bone no loss of interdental bone or soft tissue. A class 3 recession extends to or beyond mucogingival junction. There is loss of interdental bone or soft tissue that is coronal to the apical extent of the marginal tissue recession. Again, in class 3, there is a recession that extends to or beyond the mucogingival junction. There is a loss of interdental bone or soft tissue that is coronal to the apical extent of the marginal tissue recession. So, class 1 recession not extending to the mucogingival junction. Um, no loss, no loss of interdental bone or soft tissue. The class 2 is a recession that extends to or beyond the mucogingival junction, no loss of interdental bone or soft tissue. The third class is a recession that extends to or beyond mucogingival junction, and there is loss of interdental bone or soft tissue that is coronal to the apical extent of the marginal tissue recession. And a class 4 is a recession to or beyond mucogingival junction, loss of interdental tissue to a level apical to the recession. Okay, so the class 3 and the class 4 are different because the 3 is a loss of the interdental bone of soft tissue that is apical, loss of interdental bone or soft tissue that is coronal, to the apical extent of the marginal tissue recession. Okay, yeah. And the class 4, there's a loss of interdental tissue to a level apical. So in class 3, even if there is bone loss, there is not necessarily a marginal tissue reception, whereas in class 4, there is a loss of tissue also to the extent of the bone. In other words, the in class 3 there is partial coverage, in class 4 there is no coverage. Osseointegration. Osseointegration is a direct attachment or connection of osseous tissue to an inert alloplastic material without intervening with connective tissue. Direct contact between bone and implant surface. Osseointegration. So implants have a peri-implant soft tissue seal where junctional epithelium attaches. Implants have a peri-implant soft tissue seal where junctional epithelium attaches to the implant surface by hemidesmosomes. Next, 7. Bacteria associated with peri-implants. Dental implants have healthy sulci around dental implants that are characterized by a predominance of coccoid aerobic species with a low number of gram-negative anaerobic species. In contrast, the pockets associated with periimplantitis are colonized by high proportions of anaerobic gram-negative rods, motile microorganisms, and spirochetes. They also may be colonized by other species such as Pseudomonas aeruginosa, Candida albicans, and staph species. Periimplantitis is an Periimplantitis is an inflammatory process affecting the tissues around an osseointegrated implant in function, resulting in loss of supporting bone. Question number 8. Surgical technique for ridge augmentation. Some confuse choices, surgical technique for ridge augmentation. Often covered with a protective membrane, bovine, which is cow bone, processed as a particular graft material is commonly used for oral bone grafting applications, including ridge augmentation and maxillary sinus augmentation or sinus lifts. The bovine bone is classified as a xenograft, or bone that is transplanted to a recipient from a member of another species. Number 9, inverse bevel incision. Inverse bevel incision. Horizontal incisions for full thickness flaps Three horizontal incisions are usually associated with a full thickness flap design. The first is the internal bevel incision. Depending on the goal, this incision can be made 0.5 to 1 millimeters from the free gingiva. From the free gingival margin, apically displaced flap. 1 to 2 millimeters from the free gingival margin, modified Whitman flap. 1 to 2 millimeters from the free gingival margin, modified Whitman flap, or just coronal to the base of the pocket, which is an undisplaced flap. It also is known as the reverse bevel incision. This incision removes the pocket lining, conserves the outer dimension of the gingiva, and produces a thin, sharp flap margin that can be adapted to the bone-tooth junction. Inverse bevel incision. 10. Inflammatory mediators may be indicator of disease activity. The options are interleukin-2, tissue necrosis, necrotic factor, interleukin-6, or A2. So we have a scale, which one side we have disease, and the other side we have health. In the disease side, we have risk factors, which are genetics, smoking, diabetes, obesity. That's disease. In the health side, we have reduction of risk factors. In the disease side, we have overproduction of pro-inflammatory or destructive mediators of enzymes like interleukin-1, interleukin-6, prostaglandins 2, tumor necrosis factor alpha, and MMPs. In the healthy side, we have expression of host-derived anti-inflammatory or protective mediators, in which we have interleukin-4, 10, 1RA, and TIMPs. Disease side, we have underactivity or overactivity of aspects of host response, health, host modulatory therapy, resolution of inflammation. Disease, poor compliance, poor play control, and subgingival bioburden. In health, OHI, SRP, surgery, antiseptics, antibiotics to reduce bacterial challenge. 11. Which enzyme and cytokine is secreted by a macrophage? Which enzyme and cytokine is secreted by a macrophage? A. Tumor necrosis factor. B. Transforming growth factor. C. Protease. And D. All of the above. Cytokines are important signaling molecules released from cells. The cytokine interleukin-1 is important in bone resorption. Interleukin-8 is important in attracting inflammatory cells, which are chemotactics. And tumor necrosis factor is important in activating macrophages. So, tumor necrosis factor, macrophages, tumor necrosis factor. Which enzyme and cytokine is secreted by a macrophage? Tumor necrosis factor. Allograft has following characteristics except allograft has all the following characteristics except that is osteoinductive. Allografts are not osteoinductive. Allograft is a material obtained from a cadaver bone that is processed to ensure sterility and decrease the substances in the bone that can trigger host immune responses. However, this process destroys the osteoinductive capability of the bone, whereas the osteoconductive property of the graft remains. Although allograft avoids the need for a second surgical site, a greater amount of the grafted material is reabsorbed compared with autografts. So autografts can be osteoinductive, but not allografts. Allograft materials include undecalcified freeze-dried bone allograft, which is an osteoinductive material, and decalcified freeze-dried bone allograft, osteogenic material owing to the presence of bone morphogenic proteins that are exposed during the demineralization process. Again, allograft materials include undecalcified freeze bone dried allograft, which is osteoconductive, and decalcified freeze dried bone allograft. Osteogenic material that is owing to the presence of bone morphogenic proteins that are exposed during the demineralization process. So freeze-dried bone allograft is osteogenic. Next question, typical dose of nitroglycerin. Nitrostat is a stabilized sublingual compressed nitroglycerin tablet that contains 0.3 milligrams, 0.4 milligrams, or 0.6 milligrams of nitroglycerin. One tablet should be dissolved under the tongue or in the buccal pouch at the first sign of an acute anginal attack. The dose may be repeated approximately every 5 minutes until relief is obtained. If the pain persists after a total of 3 tablets in a 15-minute period, or if the pain is different than is typically experienced, prompt medical attention is recommended. Nitrostat may be used prophylactically 5 to 10 minutes prior to engaging in activities that might precipitate an acute attack. During administration, the patient should rest, preferably in the sitting position. Angina pectoralis, pain in the heart and chest that occurs during occlusion of the coronary arteries triggered by physical exertion, increased blood pressure, and vasoconstriction. Anti-anginal drugs prevent or provide relief of angina pectoralis. Nitroglycerin, nitrostat or nitrates are a coronary artery vasodilator that relaxes blood vessels to provide increased blood flow and oxygenation to heart muscle. If administered sublingually, it is effective within 2 to 4 minutes. The skin patch releases the drug over a 12-hour period to provide sustained blood levels to prevent angina. It is the single most effective anti-anginal agent available to manage acute anginal episodes. It is fast-acting and relieves acute anginal attacks in the dental office. For angina, nitroglycerin and nifedipine are usually used before verapamil. Nitroglycerin is a direct vasodilator that treats angina pectoralis and hypertension. No dosage adjustments are required in patients with renal failure. Which is not a feature of primary resistant form in amalgam preparation, which is not a feature of primary resistance form in amalgam preparation. A, adequate thickness. B, rounded axiopulpal. C, vertical wall convergence. Again, which is not a feature of primary resistance form in amalgam preparation, I think is rounded axiopulpal line angle. So, which is not a feature of primary resistance? Which is not a feature of primary resistance form in an amalgam preparation? The answers given here are all features of primary resistance, which are adequate thickness of the amalgam, rounded axiopulpal line angles, rounded line angles, and I don't know, vertical wall convergence. So, vertical wall. So things that help on retention. So buccal and lingual walls, they should converge 6 degrees pulpo-occlusally under triangular ridges, which are strong, and they should be divergent 6 degrees pulpo-occlusally in groove extensions. The rationale behind this is that they help log restoration in tooth. They keep amalgam from being too thin at margins, which provide resistance, and they preserve strength of the cuspal ridge. So next question. Minimum film thickness is an important property of zinc phosphate. A minimum film thickness is an important property of zinc phosphate. What are the properties and manipulation? Zinc phosphate cement should be mixed by incremental additions every 15 to 20 seconds. Ensuring saturation of the powder with the liquid adds strength to the cement. A frozen slab technique or decreasing the rate of addition of powder to liquid retards the setting cement. The cement film thickness is about 25 nanometers. Phosphoric acid is very acid, 3.5 of pH. So minimum film thickness is an important property of zinc phosphate. Minimum film thickness is the important property of zinc phosphate. The property of the film thickness, the ideal material will have a low film thickness. Zinc phosphate is equal or less than 25. Polycarboxylate about 25. Glass ionomer more than 25. Resin ionomer more than 25. Actually, glass ionomer less than 25. Resin monomer more than 25. Resin more than 25, and adhesive resin more than 25. And this is all the minimum film thickness that is an important property of zinc phosphate. So another way they can ask this is which of all these materials has the least film thickness, and that's zinc phosphate. Zinc phosphate should be mixed by incremental additions every 5 and 15 to 20 seconds. Ensuring saturation of the powder with the liquid adds strength to the cement. A frozen slab technique or decreasing the rate of addition of powder to liquid retards the setting cement. The cement film thickness is about 25 nanometers.